my attention is going to be only on YouTube. So fine. What is very important for each and every one of you to understand is that in our country, especially when you look at India, it is going to be extremely common, all right, for young girls to present with secondary amenorrhea, right? This is something which is extremely common in our country. So I think every family physician would have seen something like this, at least 2 or 3 or 10 such cases in their career, because post tuberculosis amenorrhea is something which is very common in our country. All right, so that is the first thing which you must remember. Second thing, the typical history which a patient is going to give you in such circumstances is that the patient is going to tell you that she had menses, but after, like, let's say 2, 3, 4 years of having menses, she was diagnosed to have TB of the chest. Okay, it was diagnosed to be TB of the chest, and then suddenly her menses stopped. All right. So typically people, I've seen this commonly. Everyone is going to treat the patient with oral contraceptive pills. Somebody is going to try Ayurvedic medicine. Somebody is going to try homeopathy, whatever, jisse jo ho gaya wo. But remember, no medical management will usually work in post-tuberculous secondary amenorrhea. That is something which is extremely important for you to know, because in post-tuberculosis secondary amenorrhea, this is what you should be understanding. See this? If I show you, this is how the uterus is, right? Hemantiban, you can see this, right? When I'm trying to talk this. Fine. So if you try and understand, this is the uterine cavity. See, the uterine cavity is going to be open. But what happens in tuberculosis or sequelae of tuberculosis is that this cavity, it fuses, it joins. That means this wall gets fused to this wall gets fused to this wall. The cavity closes down. So once the cavity closes down, irrespective of what you do, you give whatever pathy medications you want, there is no medical management when the uterus is closed. All right. This is something which is very important for you to understand, something which you must absolutely by heart in such patients. So whenever you have these patients who have come to you with secondary amenorrhea, the most important thing which you must remember in our country is a post-tuberculous infection. All right. So I want somebody to be unmuted. So I will just ask Dr. Akil Bhai, contractor, if you can just stay unmuted, because I'm going to switch, and I would just request you to stay unmuted through the session. So I'm going to be beginning my screen sharing. Dr. Akil, am I audible, right? So yes. I'm going to be beginning my screen sharing, and what am I going to do is that screen sharing is going to show you this entire video, of how these things are treated. And that is something which is very important that all of you should be aware of. So can you see this? Can all of you see this?
Yes,
Dr. Akil, this? Yeah, yes. Fine. So I'm going to play this thing, and this entire thing, actually, you will not believe this. I have recorded this just for family physicians. And I just recorded this around 30 minutes back when I got time. So I'm going to play this thing as a video in video, and I think some of you will enjoy it. It's for around 7 to 8 minutes. So just listen to this. This 7 to 8 minutes are going to be going to help you to change lives of many young girls in our country. All right. So I'll just play it now. Hi everyone, and welcome to this episode of Masterclass on hysteroscopic adhesiolysis. What is very important, as you are seeing through this video, is that this is a patient who is presented post-tuberculosis, post-AKT. These women usually are with secondary amenorrhea. It's very difficult to treat them, because remember, the adhesions which develop after giving AKT are fibrotic adhesions. As you can see, we are using the bipolar Collins knife in order to perform the surgery. One of the first steps of doing these of surgeries is to take incisions over the internal os. Okay, these incisions are very good because they help in opening up of the cervical canal. As you keep on seeing, see, this is the incision on the inferior aspect of the cervical canal. You will straight see the muscle. It's very good, and it's very mandatory to have a 3D ultrasound documentation of this uterus prior to doing these surgeries. That is because you want to have an exact idea of the distance of the cavity from the serosal aspect of the uterus along all the 4 quadrants.
As you see, we are using the Collins knife and doing extremely gentle dissection along the left
So
lateral
just
wall.
one thing for everyone. I hope you are able to see the video clearly, right? Akhil bhai, video is
Yeah.
clear and it's audible.
Yes.
Okay. The second thing you must understand is that this is a live surgery. So whatever I'm doing is actually live. Exactly same procedure is done inside the patient, and you will understand how this cavity opens up and becomes like a uterus now. Just see that. Okay. You will really like it, all of you.
Of the uterus that is visible, you can see that there is hardly any endometrium which is present. One common question which people ask is that after doing surgery for Asherman, how will the endometrium redevelop? The answer is it develops through lateral epithelialization, either through the cornua or through the cervix. So that is one very important thing which people must remember when they are performing surgeries for Asherman. Second thing which people must remember in such surgeries is that after doing a complete surgery, there is a huge role of autologous stem cell transplant in a uterus which is with secondary amenorrhea. We are one of those centers who were probably one of the first people to start autologous stem cell therapy inside the uterus, and we've had phenomenal results. We've demonstrated this procedure live across various platforms. Anyone interested in seeing how an autologous stem cell transplant is done in the uterus can easily log on to our social media platforms to have a look at that. But despite doing all of that, that means despite doing stem cell transfer, despite doing an extremely good surgery for Asherman, one must remember that only approximately 50 to 60% of the patients ultimately start showing signs of developing. That is one very important point. As you see, we are dissecting right till the level of the opening, that is till the level of the cornua. That was the cornu on the right side. This dissection which is being done, you can see how the fibers, all the fibrotic bands and the regions are keep on getting separated through the center. Do not confuse this with a septum. A septum is going to be way more different and way more vascular in most of the situations as compared to Asherman. You can see these gentle nicks is causing a huge separation of the cavity. You can very well observe that we are still not in the muscle, because the appearance of the uterine musculature is going to be very different than these dense fibrotic adhesions which we are trying to release and trying to cut. Now you see on the anterior wall of the uterus and the posterior wall, you see how hard this is. This is the actual fibrosis which needs to come out. If you leave this fibrotic tissue inside, remember one rule: the adhesions are going to recur even if you put a Foley's bulb inside the uterine cavity. Never ever forget this. This is a wide, roomy cavity, just a little bit of lateral separation of these adhesions. These are typical post-tuberculosis adhesions. Absolutely typical post-TB adhesions. You need to make this cavity wide and roomy. As you can see, the cavity is getting wide, the cavity is getting more and more roomy. Once this happens, your primary part of the surgery finishes. That means your primary adhesiolysis through the uterine cavity finishes. I prefer to do this adhesiolysis using a bipolar Collins knife. There are people who like to use cold knife scissors. Both the techniques are equally good, as long as part 2 of this surgery, which we are just about to begin in the next 1 minute or so, is done. And that part 2 is excision of these adhesions. I repeat the word, it is excision of these adhesions. Do not just incise it. All what we did right now was incision. We cut through all these things, we separated, we made the cavity roomy, we identified both the ostia. So mentally we are extremely happy. But this is not the end. You can see the cavity is not loud and roomy, right? Through the internal os. So this should not be your end point. This is part 2 where we are excising these adhesions. You can see that adhesion. It is my bipolar resectoscope which has gone inside the uterus, and now I am going to excise this adhesion out. I am going to go inside, take this adhesion out through the anterior, through the posterior. It's very important for you to remember how deep you should be going. Don't go very deep. Don't compromise the myometrium. You will get the feel of what is the myometrium once you are doing these surgeries very frequently. You can see it is an absolutely pale tissue. It is an avascular fibrotic tissue. You can very well understand the consistency of this tissue. But do not worry about the loss of basal endometrium here, because this part of the endometrium is any which way non-functional. So you want this part to be staying absolutely free. This is how you have to excise. You have to take that entire thing out, and that material which is taken out is then going to go for histopathological examination just for purposes of documentation. You can see there, we are not entering the muscle. We are just going above the muscle using our bipolar resectoscope and excising these adhesions. Please note this, that along the anterior as well as along the posterior margins, this is going to be a very important step. Any other place where you find a dense fibrotic adhesion, you must remove it. See this? Now you are seeing the removal of this fibrosis along the posterior wall. So you just dig inside a little and you come out in a single stroke. It allows the liberation of the entire adhesions. Alright? This is very important. At the end of this, we normally keep a pediatric Foley's bulb inside for inflated to approximately 3 to 4 cc. That is kept for 6 to 8 hours. That is one very important thing. Next day morning. Now, if we do an inoculation with autologous stem cell therapy, it is done in the same sitting. Next day morning, this pediatric Foley's is taken out and an interseed. Interseed is a oxidized hemicellulose graft which all of us are aware of. An interseed graft is put inside the uterine cavity. We've done this grafting with interseed for approximately 30 to 40 patients now, who are all with secondary amenorrhea. Most of them in our country, especially due to post-tuberculosis secondary amenorrhea, and the results are absolutely phenomenal. These patients are also given estradiol valerate tablets for approximately 2.5 to 3 months, along with, of course, withdrawal agents in order to induce menses. But what is important for all of us to remember is that despite these efforts, only approximately 60% of the patients are going to respond despite doing autologous stem cell therapy in virtually every patient. Usually, the fertility outcomes of these patients are not going to be so great. So, you might as well want to counsel these patients about the possible available options of getting surrogacy done whenever they wish to have fertility.
Fine. So, I think with this, I'm going to come back to our routine session and just tell you that, remember, this is very, very common in our country. So just in case, as family physicians, you identify somebody with amenorrhea, don't just say, kuch nahi ho sakta. Don't give that, okay? There are so many patients who are going to come back, do this procedure, and are going to be extremely benefited with this procedure. All right. So that is one very, very important thing, which should be a take-home point for all the family physicians. I hope you've enjoyed this session, because this was a very sweet, short session which I wanted to do. Thank you so much for joining, and I will